respiratory tracts.
How so?
Legionella, chlamydia, mycoplasma.
Okay, welcome back. This is lecture 2, or should I say review 2, for tomorrow's quiz. This lecture will cover from clonones, aminoglycosides, tetracyclines, as well as macrolides, glycosamides, flagell, and another category I'm forgetting. So before we get into drugs, we want to talk about a coverage that we're going to see that's pretty new compared to the beta-lactams. And Paulus will talk about these atypicals real quick.
Cool. So atypical pathogens. So they're classified as atypical because they're neither gram-positive or gram-negative. They also lack cell wall. So when you are staining these atypical pathogens, they don't come back with a red or purple stain. Okay. So there's 3 that we talk about: Legionella, pneumophilia, chlamydia with pneumonia, and mycoplasma pneumonia. Okay. So let's break it down. So Legionella pneumophilia, it's a gram-negative rod, but it stains poorly. Again, why? Because it's atypical. Its habitat and it's in water organism. It's waterborne organism or something. But it's in water. Okay. In terms of transmission, person-to-person transmission does not occur. Transmission is via aerosol. So this one she was talking about the AC. Okay. There are some predisposing factors, but these predisposing factors could be for anybody. People who are over the age of 55, people who are smokers, people who are immunosuppressed, or people who consume alcohol.
I can connect that.
That's what I'm saying. It can be for anything.
Yeah, but like the connection between respiratory infection.
I don't know. In terms of diagnosis, you detect for a urinary antigen that provides rapid diagnosis for serogroup 1. That's very important because with all of these, the diagnosis and the cultural things it's going to be different. So for Legionella, it's going to be the serogroup 1, bacteria only. You can also look for an increase in antibody titer. I don't know how the hell that's going to be diagnosis.
Titers is basically blood draws.
Mm-hmm. The next one is chlamydifolia with pneumonia. Again, these are gram-negative. I don't know how they get gram-negative because they don't stain, but whatever. We're gonna keep it. Transmission with this one is unique because transmission you get person-to-person transmission. This is also known as the walking pneumonia and causes 10% of the CAP, community-acquired pneumonia cases. With this one, you actually detect for IgG and IgM to kind of detect it, I guess. The third one is mycoplasma pneumonia, and you can think of TB. Wasn't somebody supposed to text Keisha?
Go ahead.
Okay.
Y'all starting?
Mycoplasma pneumonia. These are the smallest free-living organisms. Again, they have no cell wall, and you don't see them on a gram stain. In terms of habitat, again, think of TB. So TB is going to be in the what? Respiratory tract. So transmission would be what? Droplets, sneezing, whatever the case may be. You know, when you go to the doctor's office, you get tested for TB, they ask you if there's anybody in your family that has been diagnosed with TB. That's why, because it's easily transmitted. You actually culture on special bacteriological media, but it takes 10 days to grow. Okay.
So then in that case, then we would start non-empiric therapy, right?
What do you mean non-empiric?
Empirical therapy.
You mean empiric therapy?
What's empiric?
You just get in history and then just treat it.
So you get a broad spectrum drug until you get results back from culture then?
Yeah, I mean, or if you're suspecting a TB, you can do the PPD.
Yeah.
Which will come back. Or you can do the quantiferon.
Yeah. I don't know why it takes quantiferon gold test.
It's blood.
I know, but for testing.
Right away.
Really? Yeah, okay.
Did you send this to us?
Okay, go ahead.
That's it.
Oh, okay. So those are the atypical bacteria that Paul talked about: mycoplasma, chlamydophila, as well as Legionella. Note that they all transmit differently. They all require different hosts, and they all have a different way of testing their for existence on a plate or whatever testing they maybe go under.
Do tetracyclines first. Let's go in the order that she did it. So it's
Okay.
tetra, yeah.
It makes sense that way, like the other ones we did.
Yeah.
Okay. So we'll talk about tetracyclines first. Tetracyclines, as you should know what the structure looks like. So that's what's called tetra. 4 cyclines, cyclic structures. Tetracycline itself is a drug orally given 1 to 2 grams per day. Doxycycline IV oral 100 milligrams every 12 hours. And minocycline, brand name called Minocin IV or oral 200 milligrams for the first dose, followed by 100 milligrams every 12 hours. Renal adjustments are required for Minocin and Tetra. Doxycycline does not require renal adjustments. Remember that. Adverse drug reactions: there's GI, tooth discoloration, photosensitivity, anaphylaxis, and dizziness and vertigo is seen in Minocin. Okay, this is category D for tetracycline. Good against gram positive, more than gram negative itself. It is good against atypical, and that's a new idea we're learning right now compared to the beta lactams. It's also good against MRSA. Okay, specifically Minocin and doxycycline are active against MRSA. Again, this class covers atypical infections, acne, CAP, Lyme disease, Rixetta, Vibrio, anthrax, bronchitis, and a lot more that was enlisted. Drug interaction: be careful administering this drug with any iron supplements, antacids, or milk, because they will interfere with absorption. And a last drug that was mentioned is tigecycline. It's also a tetracycline drug. It's given IV only, not very effective because it has low concentration in the blood as well as in the urinary concentration. And something to worry about this drug is that it has a mortality rate that was increased while this drug was being used by previous patients. Right.
What drug?
So, tetracycline. So, one of the things we forgot to do with all the drugs is mechanism of action. So,
Yeah.
I guess the beta lactams they all do the PVP.
Mm-hmm.
So that's fine. But tetracycline, they bind to the 30S subunit and essentially kind of interrupt the elongation of the amino acid. So again, these drugs are going to be primarily used for atypical drugs, Lyme disease, mycobacterial infection. So if you're just looking at the email that she sent out, tetracyclines do cover anaerobes. However, there's a caveat to that. The caveat is it only covers a certain pathogens when we're talking about anaerobic coverage. So it only covers Actinomyces, Leptococcus. It's on the blackboard, so refer to that. So Leptobucoli, and then Arachina. So it does have anaerobic coverage, but with a caveat. Only 3 anaerobic coverage. Some of the side effects of tetracycline include GI, like with any other drugs, tooth discoloration, photosensitivity, as well as hematological effects. It is category D. It is category D. Now, again, the tetracycline include doxy, mino, and doxy and mino, and to an extent, tigecycline. Doxy and mino have 100% bioavailability. So, if you look at the dosing, I think the dosing was the same for both because it has 100% bioavailability. Tigecycline is only IV. Because tetracycline chelates with antacids, multivitamins, you have to separate your 2 drugs, separated by 2 hours or 4 hours after. No dose adjustment for the doxycycline, but renal adjustment for tetra and minocycline. Did you guys okay?
You said it was 2 before and 4 hours after?
Yeah.
Okay, thank you.
You can double check me on that.
No, that's what happened to me.
Okay. Again, no dose adjustment for doxy. The way I remember it is no dose, doxy, no dose adjustment. Okay. But tetra and tetracycline and minocycline, you do need renal adjustment because tetracycline actually shown to actually worsen kidney function. When we jump to So if you look at doxycycline dosing and minocycline dosing, it says PO/IV 100 milligram Q12. And again, that's because doxy and mino have 100% bioavailability. Tigecycline, this is from the book, has a high volume of distribution, which you would know that it's going to distribute into a lot of the tissues. Because it achieves low concentration within the urine, this would not be a drug of choice for UTI. Okay. It also does not. It is also not used for bloodborne pathogens, I guess. Okay. Now, tigecycline got a bad rep from the public because they did a study where it showed that this drug actually caused high mortalities, right? So they got a bad rep for that. But this is the drug of choice for many tick-borne diseases. Side effects increases INR, okay, and it's good against atypical. Okay, so when you think of tetracycline and tigecycline, the first thing that should go into your mind is atypical. That's the biggest takeaway from this. Okay, that's it. And know your adverse effects.
And it's also good for MRSA, right? You said that?
Yeah,
No.
doxy and mino.
Yeah.
Yeah, they cover.
Did you mention the resistance?
What about them?
The tigecycline has experiences less resistance than the other tetracyclines.
That's probably because they probably don't use it.
Yeah, that's
Yeah.
another.
And so it's a bad drug period. Low blood concentration, low
Right.
urinary
It's
concentration,
really,
mortality rate.
But the MRSA, that's a good point. MRSA, this is the second time we've seen MRSA. Doxy and mino covers MRSA.
And what was the other one that covered MRSA?
Fifth generation. Sectorally.
Tigecycline I actually made a bunch of times actually in the old hospital.
Let's look at it.
Okay, the next class.
Hold on.
Oh,
Next class is
Huh? Say it.
macrolides.
oh macrolides.
Dr. Lucky, I think she's gonna say it's good. We put her in
Macrolides. So macrolides, they bind to the 50S subunit of ribosomes. Drugs are erythromycin, clarithromycin, and azithromycin. Erythromycin 1 to 2 grams daily every 6 hours orally. Clarithromycin is 250 to 500 every 12 hours. Azithromycin is given IV or oral. Renal adjustment is required only for clarithromycin. Adverse effects to point out QT prolongation, and also something that's a benefit to use erythromycin is if patients have a GI impaired motility, erythromycin has a prokinetic effect, so it would be advisable to use erythromycin in this class of macrolides. It's a category B. There was a mistake on the slides that were given. Is good. It's effective against atypicals, just like tetracyclines. It's good against Staph aureus, streptopneumoniae. Although there's still pneumonia is still resistant to macrolides, Mycobacterium avium, as well as CAP, bronchitis, COPD, and Mycobacterium, as I already mentioned already. But in HIV patients with AIDS, you can also cover chlamydia. So you can see atypical. That's all we have to say because we know atypicals are what? Mycoplasma, Legionella, and Chlamydophila. Erythromycin and clarithromycin in drug-drug interaction can inhibit CYP3A4. If that's an issue in drug therapy, then you would advise to give azithromycin. And that's it.
Okay. So again, mechanism of action, macro, it binds to 50S, and again, it kind of disrupts the elongation of the amino acids. In terms of coverage, this is going to be a really good drug again to cover atypical because this covers Mycobacterium avium and chlamydia, which are your atypical drugs. The Mycobacterium avium, this is specifically problematic in patients. I think this is in HIV patients or diabetic patients. Something with HIV and diabetic patients there. In terms of their side effect, there's significant GI side effect, specifically with. Come on.
H. pylori?
No side effect.
Of what?
What was the question?
Macrolides. There's a significant GI adverse effect with which one?
And AGI
Which drug?
Erythromycin.
Erythromycin, right? So erythromycin is actually because what is that side effect?
Gastroparesis.
So we can actually use it in what?
Diabetic patients.
Exactly, because it promotes motility, right?
How do you use it down?
Now, in terms of cardiac adverse effect, we have to know this. And for those again that have lab tomorrow, this is going to come into play when you're deciding to pick what drug is going to work for what patient. So, prolonged QT prolongation is very common, especially with erythromycin. But you can see the QT prolongation with the whole class. Drug interactions, except for azithromycin, they are all potent CYP3A4 inhibitors. Okay. Azithromycin has a prolonged half-life, a really long half-life, and that is
62 hours.
60. Then that what because it has a long half-life, what does it allow us to do?
Those less frequently.
So we have
1 day.
I know. So we 1 day, or so we give it as a
A CPAP.
Z-pack.
Which one?
Azithromycin, the Z-pack.
Oh yeah.
These are okay. To take it back one, if there are inhibiting a ribosome at the 30S or the 50S, are they bacteriostatic or are they bactericidal? Static.
Why static?
Because they are well, I don't know the answer.
Because they're whatever was made before, they can't kill it.
Right.
They can only like
Stop the
stop halt the growth.
Right.
That's why they're static, right? Again, QT prolongation is problematic, especially with erythromycin. Drug interactions, except for azithromycin, clarithromycin, as well as erythromycin. Let me take it back. Except for azithromycin, erythromycin, and clarithromycin, they are potent CYP3A4 inhibitors. Okay. One of the drug that actually treats H. pylori is clarithromycin. So they actually couple clarithromycin with lansoprazole as well as amoxicillin to give us Prevpac. So if you have a patient that's been diagnosed with H. pylori, you give them Prevpac, right? And why do we? So clarithromycin makes sense, right? And amoxicillin, okay, it's antibiotic. Maybe it has a synergistic effect. But why lansoprazole? What is the significance of? Huh?
EPA.
Oh,
The bacteria can't thrive in the acid, in the acidic environment. They can't thrive in a basic environment.
Bingo. So H. pylori thrives in an acidic environment, which is it's only found in the stomach. So if you change the acidity of the stomach to become more basic, then not only are you making it difficult for the bacteria to live in there, you're also killing it with a clarithromycin. So it does have synergistic effect. That's why. You do renal adjustment for clarithromycin. There's a lot of stuff going on here. In terms of pregnancy, I think she had pregnancy. She put category D.
Yeah.
It's not D. Clarithromycin is C. Clarithromycin is pregnancy C, so C for C, and the rest are B. Okay, so I know there's a lot of macrolides, so let's just recap. So they're good for
Typical.
atypical. So give me some atypical. Chlamydia. So one by one. Chlamydia, Mycobacterium avium. Okay. And how do they work? Okay. So give me some side effects. Don't look at your nose. Okay? Remember.
GI side effects.
Specifically,
Gastroparesis.
I'm looking for a drug.
The drug?
Erythromycin.
Yeah.
So you can actually take that advantage and use it for diabetic patients. What else?
Why diabetic patients?
I don't know.
Increases GI motility.
Come on, man. Gotta go back to our roots.
Gastroparesis.
Okay.
Ethiopia.
Now, what's another side effect? The big side effect. that I mentioned? With
Azithromycin.
all of them, but the pronounced one is for erythro.
Erythro?
They said
What's
in the book
pronounced?
it said mostly azithro.
Erythro.
Oh yeah, most common in erythromycin, QT prolongation.
E.
Yeah.
But you can. I mean, that doesn't mean you don't. I mean, I would just classify it with a macrolide. QT prolongation.
Yeah.
Macrolide.
Yeah, I would too. Yes, because that's not something I would stand up for
That's what I'm
erythromycin.
saying.
QT in the macrolides, period.
Give me some drug interactions.
CYP3A4, statins.
Except,
It's
that-
wrong.
what else is unique about a Zithro?
It's the most commonly used.
Okay. What about the Z-Pack?
It's
Tell me the
It's a long
significance of it.
half-life.
Long
62
half-life,
hours.
62 hours.
The CYP3A4 inhibitors use that everything
Everything.
except
The A.
Azithro.
Azithro. A is for the exception. Atypical, A. A stands out, Azithro.
Or
There you
you
go,
can
A
think
for
it's the
exception.
most commonly used.
Like
Why?
A,
Because
like,
it's-
you know, like if there's something
A
A
means
before it,
not in a lot of different terminologies. I
You
got
think
you.
of the Z packs out like
It
candy.
means that in
A for
Latin.
exception?
LATIN.
I know we're rewriting words now.
I am.
Every time I see it, it's
Okay.
like,
That's it?
Are we good?
Yeah, we're good.
See,
I hope so.
What's next?
I mean, it's-
Wait, that's
Yeah.
everything? Or y'all doing a verse? That's all that verse?
So these aren't on there? These aren't on
Gastroparesis
there?
and QT prolongation?
I didn't say that was an
Metronidazole stuff, is that on there?
Yeah, it is.
I don't know.
Aminoglycosides. We have Genta, Tobra, and amikacin. All of these are available in IM and IV form, but tobramycin is also additionally available in the inhalation form. They require renal adjustments. They can cause nephron toxicity. Right off the bat, you should know aminoglycosides are very toxic drugs that are to be used. It's a category D, just like tetra, just like something
That's it.
else. That's it, yeah. See her category D for. It is also good against, huh?
This is
Being
being recorded.
recorded. Also, this is active against gram negatives. That's it. The only reason I wouldn't memorize this, but the only time when it's good against gram positive is if you combine it with beta lactam. But for us, aminoglycosides is really good for gram negative, although it's a very toxic drug. Out of the three drugs, Genta and tobramycin are the most commonly used. And know from PK that since it's very toxic, we will measure it 30 minutes after we administer it to get our peaks, and we measure a half an hour before we administer the dose for trough to make sure this drug is in this therapeutic window. That's it.
Okay. I don't know how you keep missing this, but mechanism of action.
Oh, I thought we all know that from PK.
Mechanism of action is 30S, just like
Tetra,
Macro.
oh,
No, macro
Oh,
50.
macro
Yeah,
is
that's
mac.
50. Sorry,
Max.
tetras. Yeah.
Mhm.
Tetras and
concentration dependent or time dependent?
Which one? What we talk?
Amino. Concentration dependent. So like Dobie said, we have Genta, Tobra, and amikacin. Which one is inhaled?
Toby.
Tobra. So we can use it in what patient?
Cystic fibrosis.
I paid
Yeah.
attention to my presentation. I like it. Okay.
What is this?
What's a hypothesis?
So again, these drugs, the aminoglycosides, they have very narrow therapeutic windows. These are going to be active against gram-negative pathogens, and I didn't really like when she said good activity against gram-negative and should be used with beta lactams against gram-positive. If you have a negative coverage, if you have something that covers only negative, and it doesn't cover positive, and you give a drug that covers mostly positive, of course it's gonna cover positive.
But that doesn't mean they work well
No,
together.
it doesn't mean, yeah, the
So?
synergy. Because there's some drugs that
Yeah,
synergy, it
they
doesn't do
inhibit
anything.
and this.
It
Yeah.
just, I mean,
I
just
don't know.
there.
I thought it was just okay. Now, aminoglycosides, what are they gonna? So they're gonna be good for what?
Negative.
Gram negative. So you can cover your Acinetobacter.
They go for negative? Oh yeah.
Negative, yeah. Now,
What's G and R?
gram negative rods.
Oh.
Now, these also give you. Now we're gonna go back to our old friend Pseudomonas. So these give you Pseudomonas coverage. Aminoglycosides. Okay.
They do? Dude, we don't have it on there.
shouldn't have it on there.
Adverse effect.
She did.
She did?
Totally.
Okay.
Adverse effect include nephrotoxicity and autotoxicity, which can cause dose-related cochlear and vestibular toxicity. I think that's from the book. Just know nephro and auto. The dose is based on the patient's ideal body weight, and again, this only covers gram-negative and pregnancy category B.
I thought it was atypical, so where's all this gram negative?
It's not atypical. It doesn't cover
There's no
atypical.
AIDS.
This drug is not
It's not.
atypical.
You only have 3 drugs that cover atypical.
What is it?
Macro,
Quinolones.
tetra, and quinolone.
Oh, so this one is not atypical.
This is only gram negative. And you get pseudomonas. Well, pseudomonas is gram negative, right?
Yeah.
So you expect to see pseudomonas.
Covers
Yeah.
C. diff.
Yeah.
Yeah.
Pseudomonas
I thought
aeruginosa.
this whole lecture was atypicals.
Not all of it, but
Yeah.
it's something like it's a new thing that you see now.
Miscellaneous and stuff like that.
Yeah, it's very miscellaneous.
What are the 3 drugs that cover atypical, Kwame?
That can do what?
Don't look.
What did the food do?
Atypical. Don't say it.
Quinolones, macrolides, and tetracyclines.
Yep.
What is it, Lauren?
Quinolones,
Come on.
macrolides, tetracyclines.
Yes.
Alright.
My
continue.
recall
Next.
is I'm slow.
Okay, what's next?
Clindamycin.
Clindamycin, the last one.
Oh, that one's known for something. Which one? That causes C.
All right,
a lot
new
of-
class,
a lot of-
lincosamides is a class, and for example, the example that we have is clindamycin, brand name Cleocin. This is a protein synthesis inhibitor. Did it give a size ribosome protein? No.
No, 50S.
50S? So
Is
clindamycin inhibit 50S ribosomes, just like macrolides. Is given 150 to 300 every 6 hours orally, 300 to 600, doubling the dose for severe infections, and 1200 to 1400 milligrams per day for IM and IV conversion. No hepatic or renal adjustment is required for clindamycin. Diarrhea is very significant. For clindamycin, it's very common, as well as C. diff, and that can even be life-threatening at points, at times. Nausea, rash, impaired liver, neutropenia. It's a category D. Is that right? Clindamycin is category D?
Joseph,
No, that's wrong.
I'll do it tomorrow.
That's
No,
okay.
it needs to be to death
No,
today.
that's what we changed. Pause.
That one was just an
I
extra.
have to do it. I have to go do it. Shit, you have to get the form today.
Pause.
Go do it tomorrow.
Clindamycin.
Yeah.
Category D is not right.
Huh?
It's not category D, right?
Hold on.
It was corrected.
I would guess
No, B.
C for
B, right? Okay. Well, this is a typo. Clindamycin is a category B, not category D. It's good against strepto, gram-positive, anaerobes, MSSA, MRSA, but there's still resistance seen in this spectrum. Does not cover any gram-negatives. Is useful against SSTIs, PID, pneumocystis jirovecii, pneumonia, toxoplasmosis, as well as Plasmodium species, which is malaria, for example.
Question.
That's it, Velos.
Question. What was the other one that did the pneumocystic jirovecii? Was that the
What's this?
Pause, continue. We'll get to that one.
Okay.
So clindamycin is a 50S. This is going to be a good drug for anaerobic pathogens, especially for B fragiles. You also get MRSA coverage here. One of the pronounced side effect is diarrhea, specifically diarrhea associated with C. diff. Pregnancy category B. That's the correction.
Is B instead of D?
Yeah.
Dang, dudes.
And you get gram-positive activity too. Gram-positive and anaerobes, no atypical.
It's MSSA. So MRSA is still resistant, you said?
Huh?
You said it's still resistant for MRSA?
No, you can treat MRSA. It can be used to treat this anti-MRSA.
That's it?
I'll be back.
You know, Joseph's list is not on here, that's why I don't want to take it.
I mean, she said it has to be due today, so whatever we have to give it to her.
Oh, here. I didn't do mine yet. Just put it under a door. Is that all? That's good. That's a good number. Okay.
The P2's list is
Huh?
That girl Laurel is good.
Okay. So stop the recording?
No, you can continue.
Okay. What's next then? Who knows?
Quinolones.
Quinolones. Okay.
Bactrim.
Oh, Bactrim. Bactrim, we have trimethoprim and sulfamethoxazole, which is Bactrim. can be given oral SS or DS in tablet form every 12 hours. Renal adjustment is required for this drug. Adverse effects, typical of penicillins, but one thing is that it can cause bone marrow suppression. It can also increase creatinine concentration because it blocks creatinine secretion in the nephrons or in the kidneys. It can also have a hyperkalemic effect, just like the RAAS drugs, and TEN and SGS at times. So these are very what is it called? Adverse effects that can be seen for in Bactrim. It has good activity against Staph aureus, MRSA, and MSSA, the Enterobacteriaceae species, which is gram-negatives, Staph epidermidis, as well as Strep pyogenes and Strep viridans. Is used against SSTI, UTI, pneumocystis jirovecii, which was also seen in the coverage of clindamycin, nocardia, which is a gram-positive, toxoplasmosis, listeria, which is a gram-positive, stenotrophomonas, which is a gram-negative, and this is a category D. Is that right? Category D?
Yeah.
Spectrum? Okay, so category D, we've seen category D here. We've seen category D in tetracyclines, in aminoglycosides. That's it, those three so far. Right? Okay. There's a significant interaction with warfarin. And that's it for this. And this is a folate antagonist. MOA, I forgot to mention. MOA, it basically inhibits the synthesis of folic synthesis, which is required for DNA replication or DNA synthesis. It's a drug that has two active ingredients, and these will inhibit two specific pathways of folic synthesis. Therefore, it's called a folate antagonist as a class name. Any of you guys want to add to this? No?
Okay.
Okay, what's...
Well, the adverse effects what stood out was
Huh?
SGS.
What about it?
That's what stood out.
SGS, right. We haven't seen the side effect of increase in creatinine, as well as TN and SJS anywhere else, and bone marrow suppression. I forgot how that happens, but that's also a big deal because when you think about it, if you suppress the bone marrow, you're gonna eventually decrease or suppress the production of white blood cells and red blood cells, and so that is therefore a hematological effect right there. And is a dose dependent. So we've seen dose and concentration dependent drugs back and forth. What's the next set of drugs?
Did you do fluoroquinolones?
Flagyl.
Right?
Huh? Flagyl? Okay. Fluoroquinolones I haven't done yet. We have Flagyl left and
So where's SJS at on this thing that you did?
on mine.
Oh, here it is. Okay,
Yeah.
I see it. I'm just located on here.
Fluoroquinolones, how they work is they inhibit topoisomerase 4. There's 3 drugs in this class, ciprofloxacin.
Gyrase.
Huh?
Gyrase too.
Oh, it's 2?
Yeah, DNA gyrase and topoisomerase.
Oh,
Four.
topoisomerase 4 and DNA gyrase, or gyrase 2. Okay.
No, just gyrase in general, not two.
Oh, okay,
Also.
DNA gyrase. Okay, MOA of fluoroquinolones is they inhibit topoisomerase 4 and DNA gyrase. Drugs we have is ciprofloxacin, brand name Cipro, 500 to 750 every 12 hours. IV form, it is 400 milligrams. Evelox, moxifloxacin, 400 QD, oral or IV. Moxifloxacin, 400 milligrams, we've seen the same dose. That same dose, which was seen in, where, you guys remember that? No?
What's the question?
The 400 milligram dose of moxifloxacin is the same dose as, yes, it's a cephalosporin. I can't recall right now. It was, cefexime, I think. Levofloxacin, Levaquin is a brand name, 250 to 750 per day, oral or IV form. Bless you.
Thank you.
Renal adjustment is required for Cipro and Levaquin, not moxifloxacin. So that should get you thinking in the same thing where tetracycline, we had a renal adjustment required for Mino and Tetra, but not for doxycycline. In fluoroquinolones, Renal adjustment is required for Cipro and Levaquin, but not Avelox. ADR, QT prolongation, just like we've seen in macrolides. There's also hematological effects. LFT values rises. This is an allergic reaction in fluoroquinolones. Phototoxicity is a concern. CNS is a class effect. Tendinitis has a black box warning in the fluoroquinolone classes. It can also worsen people who have myasthenia gravis. And iron chelation is also a concern. So with tetracyclines and fluoroquinolones, iron chelation is a concern. So typical counseling points for when taking supplements, iron or antacids or milk. It is effective against atypicals, strep pneumoniae, enteric GNR, which is basically Enterobacteriaceae family, but it's not active against MRSA. Where tetra is, okay, is the use. Levo and Moxie are known as respiratory fluoroquinolones, whereas Cipro is not, because Cipro has no gram-positive coverage at all. When you think about it, for example, Streptococcus pneumoniae can be a lung infection, and that's a gram-positive. Cipro has no gram-positive infection, can cover pneumonia, therefore it cannot be known as a respiratory fluoroquinolone drug. Interaction, again, aluminum, calcium, magnesium, iron, zinc can chelate with this drug, as well as don't be careful for combining drugs with fluoroquinolones that can also prolong QT. And also warfarin interaction is seen in fluoroquinolones. And one thing I added that was mentioned, Moxie can cover anaerobes, right? Okay, so Moxie has two benefits: doesn't get excreted renally, and it can cover anaerobes where the other two can't. Right? So what's it called? We've seen QT prolongation in fluoroquinolones and macrolides. We've seen atypicals in fluoroquinolones, and tetracyclines, and
No. With
atypicals.
Macrolides.
QTM.
Macrolides.
QTM?
Yeah.
Okay, macrolides. So macrolides, tetracyclines, and fluoroquinolones all can cover atypicals. Anaerobes is covered by Moxie only. And what else is also similarities in here? Okay, that's it. That's the only thing that I see that stands out. So for fluoroquinolones, the thing that stands out the most is not the QT prolongation, because we've seen it in 3 other classes, but tendinitis, black box warning, phototoxicity for fluoroquinolones, and we can see that there's respiratory fluoroquinolones that exist as a therapy. And that's about it. What's the next class?
Your metformin's on the class. Just one drug.
What is it? Oh, flagyl.
Flagyl, and then you have your rifampin.
Oh, the rifampin. I didn't even
It's
do the
an
rifampin at all.
inducer or an inhibitor?
There's 3 different drugs.
It's a inducer.
A couple more drugs left. Nitramidazole, flagyl, metronidazole. This works by basically one of the rings in here basically binds to the bacteria and causes free radicals, therefore leading to instability, like a lysis, some sort of. Therefore, clean the bacteria. 250 to 500 milligrams every 8 hours. Orally, IV, it's 500 milligrams every 6 hours. They are provided topically or intravaginally. Hepatic adjustment is required for metronidazole. Side effects, GI, metallic taste is something that will stand out for a side effect, and for flagyl.
Oh, yeah, that's huge.
Okay, as well as peripheral neuropathy, which we haven't seen anywhere else, and disulfide reaction, which we have seen this as somewhere else, which was what? The disulfide reaction was seen somewhere else as a side effect.
Septimandol, septatetin, and
Third generation, right?
septoxetin.
Third generation. So what is that class called specifically?
Streptomycins.
Cephomycins.
Something.
Cephomycins have a side chain that can cause disulfide reaction when taken with alcohol. Now we've seen it here with flagyl.
But that's for
disulfide reaction.
cephalosporins?
Huh?
Yeah.
Cephalosporins?
Yeah, cephomycin.
Did you
I
say
thought it was
that?
something else.
So disulfide reaction is seen here as well as in the cephomycins. One thing she said in class is that note that you'll still have the effects of disulfiram if you drink alcohol 3 days after even discontinuing this drug, which means that they have some sort of long half-life that they're still in the body. Because how does it work with disulfiram reaction? This drug inhibits aldehyde dehydrogenase or alcohol dehydrogenase. This enzyme breaks down alcohol. Well, if I inhibit this enzyme, you're gonna have a buildup of alcohol in the body. There's also interaction with warfarin with this drug. It is effective against anaerobes, protozoa, bacteroids, Fucobacterium, Clostridium. What am I saying? All of these pathogens are anaerobes. Okay, anaerobic pathogens. They are bacteroids, Fucobacterium, and Clostridium. That makes sense. Okay. But they are not effective against aerobic infection. So when I see that they are only against anaerobe, not against aerobic at all, what does that ring in my head? What class is similar to this?
We just talked about it.
What's
We
his
just talked about this. The
What's the question?
A.
I thought
Hey.
it was Moxie.
It's Azithromycin. What's the question?
No, what am I thinking?
This drug this drug covers Moxie, but I'm talking about class.
Oh, class, sorry.
So natural flagyl, Flagyl covers anaerobes only, no aerobic.
Okay.
It's the class that's the same thing.
Second generation.
Well,
It was in these slides. This lecture we're talking about right now.
Macrolides.
Monobacterium?
Amino, right?
Right.
Aminoglycosides.
Aminoglycosides are good against gram-negative.
Wait,
Is it against anaerobes or no?
what was atypicals?
Gram negative.
That was second
Gram
generation
naked.
cephalosporins.
What's your question? I'm so
Oh, sure.
confused now.
Sorry, I thought this covered anaerobes too.
No.
No.
Okay, I'm thinking of gram-negative. I mean anaerobes.
No, because I thought that too for Enterobacter. Every
Yeah.
time I saw Enterobacter.
So yes, then yeah. So I guess the only anaerobes we've seen so far in this lecture is against Moxie, as well as where else have we seen anaerobes here? Clindamycin, and now we've seen anaerobes here in flagyl. This is where the C. diff comes into play. I think it was you guys who asked for this, or who else? Okay, so remember in the beginning we talked about C. diff, like drug of choice.
Yeah.
So this is very good for C. diff, intra-abdominal, brain abscess, vaginal trichomoniasis, H. pylori. What do I see common? All these pathogens thrive in an anaerobic environment where they are oxygen deprived.
Okay.
So C. diff doesn't require oxygen. So this drug of choice is the drug of choice for C. diff, flagyl is. What else? So now that's what we see. Again, flagyl what stands out, metallic taste, peripheral neuropathy, and the fact that it's a very good against anaerobic infection is the drug of choice for C. diff.
I have enough for it. Make up extra.
Oh, okay. Just let me know.
So, and then last but not least, we have
We didn't do those, yeah.
yes, rifamycins.
Oh, I don't know.
Rifamycins, we have rifampin, rifapentin, and rifabutin. These, how they work, they bind to the RNA polymerase, therefore automatically you should know that RNA is going to be suppressed, or you ain't going to make RNA. It is good against gram-positive and negative, and some mycobacterium, so a little bit of atypical. Rifampin is used in combination to treat staphylococcal, right, positive, as well as prosthetic valve endocarditis and bone infection. That's to me what stands out for a clinical use out of all the drugs we talked about from penicillin period. And that makes sense because it says retain hardware, meaning that basically when you give a surgery to replace either a joint or a prosthetic heart valve, it's metal. When you insert the metal, you're gonna have opportunistic pathogen that's gonna get on the surface and flourish in the body. So that's why they have antibiotic beads that they put with the actual device and implanted in the person to prevent those kind of pathogens that happen or infections that happen. LFT can rise. There's also some GI issues such as nausea, vomiting, diarrhea. One thing to also know is orange discoloration of urine and tears. This is very common. It's easy actually to know this because if you look at rifamycin itself and you mix it with solution or saline, it becomes a really bright orange color. Rifamycin itself. It's a CYP inducer, which we all know. And rifabutin is a less potent inducer of CYP, so if that's an issue with interaction, then you would go with rifabutin.
Can you say it again?
What?
For infants?
Paulos?
I am the remember.
Me too. Otherwise, the video is recorded.
So, this ampicillin for the atypicals, that's not supposed to be there, right?
Ampicillin, it is. Well, we don't like it, but you can treat against atypicals if you combine it.
That's what I was saying.
If they like them, yeah.
That's the unison though. It's not unison?
Atypical coverage.
Oh, sure, yeah, anaerobic coverage, not atypicals.
So why is
Yeah.
that? Did she make a mistake?
It's a mistake. It's the unison, right? With the anaerobic.
I don't know if it's a mistake. I mean, she put it there for a reason.
No, it's a
Just
mistake.
She
It's
only
not
category
not
for that.
Oh, we actually sorry. We didn't talk about. We didn't even look into that. We didn't understand why it was atypical.
I told
We didn't like that idea.
I told King to email her and ask her,
Medium
but he never
mycoplasma.
It doesn't.
I did. I think. Well,
It messes
I
up
know
with the
it's
whole
an
idea
anaerobic.
of how we thought about the process. We've seen atypical where in this
So,
lecture,
This
yeah.
one stay with the three.
Yeah.
Alright guys. Good job, thanks.
Okay, Paulos, you can cover. Go over what you missed.
Can you?
What'd you leave off? Rifamycin and Rifampin?
I'm weak with the rifampin.
It's only one slide.
Okay, well that's maybe why I'm weak. I
Yeah,
haven't looked at
kinda.
this slide.
Okay, Laura.
Where's it?
Michelle.
This
Go ahead.
one slide.
So now Paulos will review everything that I reviewed because he wasn't here, so he missed it.
Okay, so clindamycin again. Clindamycin binds to the 50S subunit. Clinical uses are gonna be. These are gonna be your like weird pathogens. So this is your pneumocystis, Jerevaki pneumonia, toxoplasmosis. These are again like your weird ones. In terms of spectrum, this is gonna have a really good anaerobic activity. It's also gonna have a gram positive activity. For the anaerobic coverage, especially with B fragiles, remember? We have where's my chart?
Yeah, flagell.
Not that chart. My bacteria chart. Alright. So you see, this is whoa. Never mind. Okay. So spectrum it covers. This is the second drug, other than the fifth generation cephalosporins that covers MRSA. Again, anaerobic coverage. In terms of adverse effect, diarrhea is going to be a big side effect, and it's specifically C. diff induced diarrhea. You can also have impaired liver function. This is pregnancy category B and not D. All right. What's next? Next is Bactrim. Bactrim is actually a really good drug. Right? Bactrim inhibits the folate biosynthesis.
Does that make it bacteriostatic or cytal?
That's not it.
I'd say cytal. I don't know. I'm not sure. Inhibits steps in the biosynthesis. It has really good activity against gram positive and gram negative bacteria. Spectrum S. aureus, both MRSA and MSSA. You can use it for your S. pyogenes, E. coli, Proteus, Salmonella. Cause you can kind of use it for the most part for the spice A organisms. In terms of side effects, hypersensitivity, rash, it's common, but this is more common with immunocompromised patients. SJS, dose-dependent bone marrow suppression. This is because you have the folate deficiency. Also, the one thing that stood out to me was the increased creatinine and hyperkalemia, not hypokalemia. We saw hypokalemia where?
Nafcillin.
Yes, ma'am. So this one has no coverage on AAP. What do I mean by AAP? So it doesn't have atypical coverage. anaerobic coverage, pseudomonas coverage. Please correct me if I'm wrong. Anaerobic, atypical, pseudomonas, and enterococci. I think. Is that correct?
It's on my list, so it looks right.
Something he's made up
Yeah.
himself.
No AAPE, API, no API.
Oh.
So wait,
Cover them.
it does cover what again?
It doesn't cover atypical,
Okay, good.
anaerobic,
And nerves. Okay, good.
pseudomonas,
Take those.
Gram negative.
and enterococci.
And what drug
Positive,
is
okay.
this?
So what does it cover then?
Just RS, MRSA, and MSA.
So
Wow.
to fire rapid from that, enterococci, drug of choice for that.
I guess one.
Amino.
Amino class. So what
All
specific?
gram positive.
So what drug specifically? Ampicillin. Yeah. And then
What?
ampicillin. Remember ampicillin?
For what drugs?
What about-
Enterococci. Enterococci.
Yeah.
And then you see pseudomonas.
Mhm.
What covers pseudomonas?
Start from the top. Start from the top.
Start from the beginning.
Timentin.
No. I want the class.
Natural penicillin.
Yeah, anti-pseudomonas
I know what
penicillin.
he's talking about.
Pseudomonas,
Oh,
pseudomonas coverage.
pseudomonas.
Yeah, anti-pseudomonal penicillins. Which
So
is
if there's two drugs in that class though, so just say
piperacillin and piperacillin, and then it's
just say
timentin
anti. Okay.
for the combo.
After that, what's next?
Zosyn.
They already said the anti-pseudo drugs. After that class, it's what we go up. What else can you cover? Covers anti-pseudo. Now we penicillins, Now
Third
Cephs.
generation.
Cephs now
Third generation.
because that's penicillin last generation now, right? Anti-pseudos, we got that. Now we enter Ceph. What Ceph covers pseudo?
Cephalosporin.
Cephalosporin.
Septazidine.
How about the bottom one? Trazodone. The
Septazidine.
force of traz, whatever.
Septazidine.
Septazidine.
Yeah.
Okay.
Antaflora.
And now we continue. That's third generation. Okay, how about the fourth? Yes. What's it
No.
called?
Cefepime,
That
Brand
covers pseudomonas.
Maxify.
And then go down. Fifth generation. Cephalosporin.
Septariline and Teflora.
Septalion. No, right?
It doesn't
No.
cover.
It doesn't,
No
yeah.
pseudomonas.
It doesn't. Okay. And then continuing. How about the carbapenem?
Carbapenem.
Everything except
Everything, right?
ertapenem.
Okay, monobactam.
No.
No.
No, yeah. You get pseudomonas coverage. You don't get gram positive bacteria, but you get pseudomonas coverage.
Yes.
Yes. Right.
Okay.
Does anybody remember what she said about? It's an acronym. I can't remember. It's like KPC, something like that.
Yeah, that is for
Yeah,
the
what is
Klebsiella, Enterobacter, and
Klebsiella, pneumonia,
and
carbapenemase.
Shaganella and Salmonella.
What?
Salmonella.
Okay.
They're gram-negative rods. They're like high risk.
Is it on the slide?
Continuing.
Or she just
Stands
said
for Klebsiella, pneumonia, carbapenemases.
Yes.
it? Okay.
What's the question?
You
Huh?
were talking about
KCP, right?
Yeah.
That's what
Oh,
it stands
KCP.
Okay.
I thought he was talking about
You good?
the KEE.
All right.
The C.
So no.
for.
The inter-
Okay.
The enterobacteria.
Yeah, KPC.
Oh, I don't know.
Okay.
That's what it
Oh,
stands
yeah.
for. But like,
We're
what
recording.
about?
We gotta.
I know.
No,
Okay.
that's what it stands for. But
We're
what about
recording,
it?
Ken.
the drug. Pfizer, what's the drug
So-
that covers KPC?
Avocats.
That's what she
Just
said.
finish it.
Avocats.
How's it done?
It's the only
Okay.
drug that covers it.
Okay, got it.
King, what's an avocado?
Klebsiella, pneumonia,
Oh, no.
carbapenemase.
I'm gonna find out.
Avocado and something.
Yeah.
I just asked
Well,
all
guys,
that.
we're recording, so let's.
Please let's continue. Okay. So we stick our penems. Yes, monobactam does cover gram-negative and pseudomonas, not gram-positive. Okay. Now we went on to the next lecture.
Tetracycline.
Pseudomonas. Okay. Tetracyclines.
Dude, tetracycline, I mean, it's gonna go a lot faster if we all participate.
Yeah.
Tetracycline? Pseudomonas coverage or no?
No.
What covers, what is the one thing that next is macrolides.
It's atypicals.
Macrolides, you get pseudomonas coverage?
No.
You do?
I don't know.
No.
Where do we see pseudomonas basically in this lecture?
You don't.
We actually did.
No, you don't.
macrolides.
You don't see pseudomonas coverage with
What?
Macrolides.
macrolides.
Oh yes. But I'm talking about like in this
I don't
whole.
like this chart.
It's accurate though.
I don't like that. It's too simplified. I feel like.
Oh, they have words with it, but I'm just using it as a guidance for the pseudomonas.
Which
Oh, yeah, I
is
remember
similar
now.
to the tetracycline?
It was clindamycin.
Versa.
Atypical. And MRSA.
No.
Yeah,
No.
yes.
You said atypicals, right?
Yeah, for sure.
Oh. So there's no way. There's no pseudomonas at all then
There
in this
is,
lecture.
There is. There's like a couple.
Oh yeah, I added. There's only one.
Let's just keep going. So
No.
tetra, no. Macro, no.
No.
Clenda?
No.
Yeah, no, Clenda.
Clinda's anaerobe.
They're all no. There's only one that you mentioned.
Nitro? Metronidazole,
No.
quinolones,
No.
Yes.
Really?
Cipro.
Levo, and Cipro.
Yep.
For anaerobics?
No, pseudo.
I don't know about that.
What?
I
Just
know.
You mean pneumonia?
You know, there's a lecture that talks about all of that, right?
Since when does
That's yesterday's lecture.
Levaquin cover Pseudomonas? I thought it was only
What
Cipro.
did you see Pseudomonas on?
Yeah.
Levaquin is actually better than Cipro.
No.
Mm,
I had to look it up.
What's this?
Yeah.
The book said. Okay.
Oh. Yeah, I forgot to add that. Okay.
See?
This would have been a really nice chart had I not written like a first grader.
Levo plus
You guys want this?
Cipro
Is that all the coverage?
Can you send me that? What is that? Where did you get that?
pseudo. So people online, we've added Pseudomonas, we got to, so Levo and Cipro can also cover Pseudomonas, just like
Yesterday's
aminoglycoside
lecture,
can cover
there's also
Pseudomonas.
Pseudo treatment is on here. Piperacillin, Zosyn,
Yes.
Exactam, Cipro, Cefepime, and
Exactam.
Ceftazidime.
Yes, that's one
That's
back
it.
them.
Those are the only pseudo treatments.
Ceftazidime. Oh yeah, she didn't put Oh, Cipro, yes. She left out Levo.
Levo is actually better than Cipro. I don't know actually. I don't know why. Because the book said it's actually better
And then
than
she said.
Cipro.
So for this whole lecture, right here, pseudo. Quinos, Levo, Cipro only, Pseudomonas, and aminoglycosides. She didn't have that.
There's more here. Well, we haven't done these drugs. Imipenem, Ceftazidime.
Also,
we did
aminoglycosides.
Yeah, we did.
That's the only thing we've
Right,
done. The rest we haven't done.
Eripenem covers Pseudomonas, right?
Which one?
No.
Yeah.
It doesn't.
E
It's
for
the
exception.
exception, the P is the exception.
All right.
Oh, this is cool. Okay.
Okay.
Just pause the recording. That's it.
You don't want to finish off yours? All right.
I mean, I'll do it. I mean, if you want to.
Yeah, go ahead. Which one? Okay, so what was the last thing we were talking about? After clindamycin, you were on Tetracycline, right?
Quinolones.
quinolones. Okay.
I did Bactrim and then now quinolones.
Okay.
Quinolones. These are the quinolones. Quinolones, they're such a good drug. They cover for us gram negative, gram positive, atypical, but they have no MRSA. No MRSA for quinolones. The way how they work is they inhibit the DNA topoisomerase, which is the enzyme that's responsible for unwinding and winding of the DNA. So essentially they lock it, again, activity against gram positive, gram negative, atypical organisms. There's a caveat on that one. Adverse effects, CNS symptoms, QT prolongation. Where did we see QT prolongation before?
Azithromycin. And
Macrolides.
erythromycin.
Macrolides, just the whole class, macrolides. But specifically,
Erythroid.
there's a big, what is the biggest side effect in this class? Other than the QT prolongation?
GI.
No, that's
Photo.
weak. No,
For which one?
for quinolones.
Black box warning.
For,
Quinos.
The tendon
I know I need the black
Oh,
box.
tendinitis.
Yes, tendon rupture. They also have photosensitivity. They also, the other thing, they worsen myasthenia gravis. They also have ion chelation.
Just like tetra.
Use Levo and Moxie for respiratory. The Levo and Moxie are respiratory quinolones. So listen to this. Levo and Moxie are respiratory quinolones.
Mhm.
Okay. Cipro and Levo, they're cleared renally, and you can use them for Pseudomonas coverage.
Repeat that one more time.
Levo and Moxie, moxifloxacin, they are called the respiratory
Oh, yeah.
fluoroquinolones.
That was on yesterday's lab.
Yeah. And Levo and Cipro, they are cleared renally, and they cover Pseudomonas.
Where did you see that one?
Is that
We
the
did
reason
it.
why they're used for UTIs?
Once we get all the information from the lectures,
Yeah,
we don't go
I mean,
back to the lectures anymore.
It seems like
It's
you
not
can use a lot of
divided.
things for UTI. So
It's right here.
We're saying specifically. Okay.
I don't know. I mean, I don't know. I really don't know. If you ask me a question of how to treat UTI, I can't really tell you like.
What drug? What was y'all's
Metronidazole.
medication?
I mean,
UTI?
UTI, definitely Bactrim. And then we also have
Quinolones too. and Bactrim, yeah, and then some of the
What
penicillins.
is this?
Now I told you guys that quinolones cover gram-positive, gram-negative, and atypical bacteria. Moxie adds on an anaerobic coverage. So moxifloxacin max has max coverage along the board. So you have gram-negative, excellent gram-negative, good gram-positive, atypical, and anaerobic coverage. Does that make sense?
But no pseudomonas.
Mm-hmm. The other thing with fluoroquinolones is this can be used in ESBLs, extended spectrum beta lactamases. This is there's only two that can be used for ESBL. This is one of them, and then carbapenems is the other one.
What does that mean if it can be used in ESBL?
So you have bacteria that are going to produce beta lactamases, like really strong beta lactamases.
Okay.
Like some that can empower the beta lactamase inhibitors. That's how I'm looking at it. So if you have a beta lactamase inhibitor like I don't know, Zosyn.
Yeah.
If your bacteria is an ESBL and you use Zosyn, it's probably not gonna
Work.
Yeah. That's what that's how I'm looking at it.
Okay.
So these are your very resistant pathogens.
Mm-hmm.
Again, you get no MRSA. It's the only thing you're not getting with
I feel like
fluoroquinolones.
the only thing we got from Bactrim was MRSA, no?
Bactrim, we got MRSA.
Tetra.
That's it, right?
Did we get MRSA for Bactrim?
No,
Yeah.
I don't see that anywhere.
For Bactrim, I'm looking at it right now.
We get MRSA?
Yeah, Staph aureus.
Oh, sorry.
Remember, Bactrim was a really
Oh,
good drug.
S. aureus. Yeah, MSA and MRSA. Yeah. Essentially, yeah. That's a good
And
catch.
it's it's gram positive and gram negative.
Right.
Bactrim was a really good drug, yeah.
But it doesn't do anaerobics.
It doesn't.
Mm-mm.
It doesn't.
So it's
What
not
doesn't?
this drug, fuck this drug.
Bactrim.
It doesn't do what? Anaerobes?
It doesn't do anaerobe, it doesn't do atypical, it doesn't do pseudomonas, it doesn't do enterococci.
It only does gram positive and negatives.
You can just say it only does MSSA and MRSA.
Mm-hmm.
Just save time. I think. The fluoroquinolones, again, what coverage do they have?
It depends. Which one are we talking about?
Huh?
I feel like it covers everything.
It does. Except one of them covers everything.
Except anaerobes. So Moxie covers anaerobes.
Moxie covers anaerobe. And which ones are respiratory quinolones?
Lysol.
Levo and Moxie. Which ones are renally cleared?
Levo and Cipro.
And which ones are pseudomonas?
Just one Mox.
Levo and Cipro.
Levo and Cipro.
Just kidding.
They're such a good drug. I don't know why we don't use them.
What?
Resistance.
Cipro?
Yeah.
Cipro is used for everything.
Just the whole class.
Yeah, it's
It
resistance.
is. That thing is used all the time.
Next is metronidazole, Flagyl. Flagyl, it can only cover anaerobes. Not even, I think, can it cover bacterial anaerobes or protozoal anaerobes?
Anaerobes in general.
Both.
Protozoa also. That's parasites, right?
Covers
Okay.
both.
Oh, the cup is both. So, the way how it works is it forms free radicals, which are thought to damage the DNA and lead to cell death. They cover gram-positive, no gram-positive or
Anaerobes.
gram-negative coverage. You only get anaerobes. Again, some of the side effects include GI, metallic taste, dose-related peripheral neuropathy, disulfiram-like reaction with consumption of alcohol. And this is because it inhibits the aldehyde dehydrogenase.
Fly, Joe. They only cover the air. No air.
Okay. Category B, anaerobic bacteria, anaerobic protozoa, parasites, C. diff, mixed and
Drug of choice.
Fun fact, for those who drink beer, they say that if you actually take a spoonful of yeast before you drink, you will never get drunk.
Mhm.
Because yeast contains alcohol dehydrogenase, which breaks down the alcohol.
So you're
You're just
you're consuming enzymes.
No more
Drug of choice too for C. diff.
No
So
more
they say like mix it with yogurt or something, and then
That's why I told you to eat yogurt.
yeah,
It still don't
Yogurt has
work. I
yeast
have
in
a
it.
2-drink.
Also, it's drug of choice for C. diff.
drug of, yes. You can pause it. We are done, ladies and gentlemen.
All right, guys, that's it. Again, at your discretion, use this with your notes and correct us if we're wrong. Good luck tomorrow.